Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral fully occluding earwax, and I'm commencing with their left ear first, which is the ear that they were experiencing most symptoms from. Interestingly, however, they actually had more wax in their better, inverted commas, right ear. And the reason why this ear was more symptomatic was because, as you can see, this wax is really impacted. It's squashed in. The patient said they didn't use a Q-tip or cotton swab, but they do wear in this ear an ear mold, a sleep plug at night. And it's for the reason, I believe, they lay on their right ear and their left ear is therefore more exposed, and where they live, they have a lot of traffic outside, so it helps them to sleep at night. So I suspect this is the reason why. By wearing the earplug here, it's fully compounded and impacted this wax. So I've just used some medical grade olive oil spray. I want to soften the surface of the wax to get a better suction grip. I also want to lubricate the side canal walls. And what I'm trying to do here is just separate it from the anterior canal wall. Now, there's a few matted hairs in this wax which can make it a bit more difficult and challenging to get a suction grip. So again, I'm just going to the floor of the ear canal. I want to try and lift this away. But when the wax is so impacted and squashed, it almost cements itself against the canal wall, and we've got to be careful because I just don't know how thick that layer is, and if I apply too much pressure with the suction probe, we can quite easily lacerate the skin that lines this part of the ear canal, which is extremely thin. It's less than 0.1 millimeters in thickness. So again, I'm just going to the back part of the ear canal, just trying to separate the plug from the peripheral aspect of the canal wall to help mobilize it. There's a bit of skin involved there as well. And this is this consistency which can be a bit challenging to remove. Sometimes if you have really dry wax, it comes away in pellets, but when you've got slightly softer wax, it really adheres itself and it sticks to the ear canal. And this is where, again, the olive oil is helpful. It helps to break that bond, if you like. So they've got quite hairy ears at the entrance, so I just want to insert the endoscope through those hairs, if possible, to prevent any smearing. Sometimes it can be challenging. Yeah, I'm just working posteriorly and inferiorly, so to the bottom back region of the ear canal. And you can see some of these strings of skin is coming away. There's another one there. And I'm just trying to peel it down and away from the front part, from the top section of the ear canal. You can just see how impacted this is. So this is a 14 gauge suction probe. So it's has quite strong suction, and I've got a pretty decent suction grip here, and even then I'm really having to tug this and pull it away. And I think when I remove this, the posterior, so the back section of the eardrum will be visible. Let's have a look. There we are. You can see the blue tinge, so that's the eardrum, but they've got all this wax still adhered to the front part of the ear canal and also the roof. This wax was actually a bit more dry and hard, and because the tail end is on the eardrum, when you're trying to suction it, you're obviously having to position the suction tip on the surface of the wax, and that does apply a bit of pressure, so it can actually push the wax momentarily a bit more on the eardrum, which sometimes the patient can feel, and I think they did initially when I was doing that, just in this region. So I think I've just put a bit more oil to lubricate. I'm hoping some of this oil seeps in and around and in between the wax and the eardrum, just to give it a lubricated surface to help facilitate its removal. You can see it's slowly coming away. When I do eventually remove this plug, there is a bit of wax and skin still adhered to the eardrum, which we also removed. You can see the bottom. So not only can we see the back part of the eardrum, we can also see the southern hemisphere. You can see the light reflex there. So light reflex occurs because of the orientation of the eardrum. So in this there left ear, the top right part of the eardrum, so let's label it northeast, is more lateral, so it's closer to the entrance of the ear canal than the southwest region. But in the center of the eardrum where the umbo is, it kind of pinches the eardrum inwards, so it gives the southwest region of the eardrum more of a flatter surface, so it's not orientated at an angle. And as a result, light reflects from that region. It collects because it's a flat surface, and it bounces the light back towards the entrance of the eardrum. If that part of the eardrum wasn't pinched inwards, then light will just reflect towards the front part of the ear canal and it will be absorbed, so we wouldn't see the light reflex. So quite often a light reflex is used diagnostically to state that an eardrum is healthy. It's not always the case. Sometimes you can have a light reflex present, because as I said, the light reflex is more to do with the orientation of the eardrum. But with some ear pathologies, the eardrum is either bulging, so it's no longer pinched in, or it's actually more pinched in, so you can get abnormal light reflex. But I wouldn't use it solely as a diagnostic tool to say that someone's got a healthy eardrum and there's no middle ear pathology, so no infection behind the eardrum. And similarly, if someone doesn't have a light reflex, it doesn't automatically mean that they have got an ear pathology, but it can sometimes be a useful guide. You can use that information alongside other examinations, other assessments that we might perform to reveal if there's a pathology present. So you can use that information as part of a test battery, basically. There's just a bit of skin laterally. I'm just going to see if I can remove this. Again, this has been pushed, so I'm guessing the sleep plug, it's pushed this skin and wax right up against the eardrum, and it's almost crusted, it's solidified against it. Now, there is a bit in a moment that you're going to see. You can't see it quite yet, but there's a patch of skin, I think just beyond this, where I later go back to try and remove it, just to make sure there's nothing sinister underneath. If you've been watching my videos with the last couple of years, you'll notice that sometimes we've cleaned the wax and everything looks fine, but there's a bit of white skin like this on the floor of the ear canal. And it doesn't look anything initially to worry about, but when I peel it away, you can see there's an ulceration there, there's some exposed bone, sometimes there can be an infection there. So I'm going to go back for that. I just want to make sure I've not left anything behind in that region, just to ensure I've not missed anything. Unfortunately, in this case, there's no cause for concern. But previously, when I've removed blankets of thick skin like that, underneath there's a canal cholesteatoma. Sometimes you can get a benign osteonecrosis. That's the benign osteonecrosis is where the bone starts to essentially decay and break down because of a lack of blood flow. Whereas the canal cholesteatoma is when you have a dead skin cyst, and this dead skin cyst releases proteolytic enzymes which essentially start chewing up flesh and bone, and it can spread and it can infect the bone around the ear canal, the temporal bone. It can be quite dangerous. They're very rare, mind you, an external auditory canal cholesteatoma. So just here, the patient was slightly twitchy, but managed to just get that, or more or less all of that white skin there, and there's no exposed bone, so there's no cause for concern. Now, they have got quite a wide floor of the eardrum, near the eardrum. You can call that the annulus region if you like, or I think technically speaking it's more the inferior recess, because the annulus is the part of the ear canal near the eardrum where the pars tensor is. So the eardrum can be subdivided into two parts. The pars tensor, which is the main part of the eardrum, and the pars tensor is typically the part of the eardrum from about 1 o'clock, 2 o'clock maybe, to 10 o'clock, 11 o'clock. And where the pars tensor is, you typically see some fibrocartilage, some white cartilage, quite thick, and it helps to stretch the pars tensor. And typically you call that the annulus. That's the proper name, that region. But here, the widening was probably more at the floor of the eardrum. It wasn't wide all the way around the periphery. So this is their right ear. They've actually got more wax here. It's a lot drier. Now there's a bit of an opening, so it's not impacted, it's not squashed in, but this ear is a bit more hairier and it's a bit more narrow. And because of the consistency, I'm going to use both microsuction and the right angled ear hook. I'm just trying to penetrate the tip of the hook into the wax, as you can see. And as I'm bringing it out, it's just getting trapped in this region of the ear canal called the isthmus. So the isthmus is essentially a medical term. I think it's also used in other walks of life, but medically it's used to define a narrowing in part of the body. So in the ear canal, there's two narrowings. The first one is between the first and second bend, so it's in the outer third, and most people have a second narrowing closer to the eardrum, about 0.5 centimetre away. So I'm just trying to rock this out. But what I'm going to have to do is insert the endoscope past the first bend, and I'm using the endoscope to stretch open the ear to widen it so I can get the ear hook in a better angle, so I can rotate it at the roof of the ear canal. So once again, I'm using the endoscope, I'm going to stretch it, and that's why sometimes I read some comments, why are you so close to the wax? Well, I'm using the endoscope to stretch the ear. So for that reason, the endoscope is going to be close to the earwax and also the hairs. Now, sometimes, and actually we do train specialists as well if they struggle to stretch the ear with the endoscope. That's probably the main skill that a lot of people struggle with, to stretch the ear canal open using the endoscope. So if someone really struggles, we do train people to ask patients to help them, or their loved ones, where you can ask them to actually retract the pinner to stretch and straighten the ear canal. So I'm just trying to wriggle this out. Now at this stage, the endoscope is not actually in the ears. You can probably tell it's outside where these hairs are protruding. And in a minute, I'm going to rest the endoscope against the tragus. So the tragus is the triangular piece of cartilage that we have probably about 1 centimetre or so in front of the entrance of the ear canal. So because I've brought this forward, I can feel I can wriggle it out without having to stretch the ear open anymore. So I'm rocking it left to right. And as I am, I'm coming forwards. And you can see it's revealing itself. So I'm just trying to get a better suction grip here. I'm kind of rocking it up and down now. And the oils help to lubricate the surface of the wax plug. Otherwise it'd be quite dry and a lot of friction, which make it a bit more tricky. So this ear canal had a much wider, or more prominent widening, should I say, of the inferior recess. You'll see that in a moment. So that plug's separated in half. So I'm just going back in. I can just wriggle it around in circles. Probably could have used the ear hook, but I felt it was coming away, so I just continued. I think it's just about to come away. In fact, it probably would have been a bit easier using the hook, but once you're there, you just carry on sometimes, because with the suction, you got to, I like to sometimes switch the suction off so it's not making any noise, and you have to make sure it's securely, I've got a little clipping mechanism, so the tip is not in contact with any dirty surfaces, and then you have to get the ear hook. You can see that widening I was referring to. So that might have just been anatomical. The patient's ear canal's just like that from birth, or they might have had some sort of pathology before, which has caused the widening. Well, I hope you enjoyed that video, guys. Take